friends, welcome aboard the EGVRS tour around the retina world in 30 days. In this tour, we will get to meet the stars of vitreoretinal surgery around the world. We will get to know more about their personal life, their success stories, their dreams, and even more. For 30 days, we will roam Mother Earth exploring the retina world around us, communicating and learning from each other. Not only about the retina and the vitreoretinal surgery, but also about the wisdom of life. Our stop today will be in Europe, where we shall land in Sussex, UK, to meet Dr. Giampaolo Gini, President of the European Vitreoretinal Society, a figure in vitreoretinal surgery. Moreover, a dear friend of mine and an old friend of the EGVRS. Dr. Gini is Italian, but has worked in the UK, has been working in the UK for many years. Dr. Gini participated in many of our meetings and even our teaching school, our training school. I remember when we first met at the Cairo airport, together with our late friend, Dr. Follini, years ago, where the EGVRS held a meeting, a very interesting, nice meeting, a memorable meeting on the Nile cruise. It's a real pleasure, Giampaolo, to have you on our tour around the retina world.
Thank you, Mahmoud. Thank you so much. And you know that all you said applies in reverse to you as well, and to all the friends in Egypt. I think I have a very special relationship with your society. I have so many friends in Egypt, and I have a great esteem of vitreoretinal surgeons of your kind, yourself and the other friends that do perform some exceptionally good surgery. And I've always been very proud to show whenever I could your work, because it truly is remarkable. Egypt is a very special place to me. Whenever did you not tell me once that if you touch the water of the Nile or drink it,
the water,
which I did not do. But I did touch it, and you do return to Egypt, and I have returned several times, and I've always been very happy.
You're always welcome. You're
Thank
always
you.
welcome.
Thank you. Yeah.
So, a question. Let's start our personal part with your English. I mean, you were one of the very few Italians I know with impeccable English. How's that?
Yes, well, that's not due to any particular credit on my part. It's just that when I was a child, my dad's work brought us to the States. My dad was the head of Agip, USA, so as you know, an oil company, which had a subsidiary in New York, and he was asked to head that subsidiary. And so we did. I went to the States, to New York, and specifically when I was about 7. And then eventually my dad decided that he wanted to retire in Italy. Therefore, we returned to Italy when I was about 17. So it was a long time in the States, and I did pick up the language. So it's nothing special. And that, may I add, perhaps anticipating one of your questions, is one of the reasons why I am in the UK now, but we will get to that, I imagine, later on.
So, I mean, you did not grow in a family of doctors, actually. So
absolutely not.
How did you end up being a doctor then?
I did not grow up in a family of doctors, that's true, but I had an influence. I think I grew up in an era when medicine was developing very rapidly. So my best friend's father was in the US, was a GP. and just listening to his stories fascinated me. And I think that's when I started deciding that I would become a doctor. So I was about 8 or 9, maybe 10, and I did start going with him to the medical meetings, which were for GPs in general in those days, and trying to understand what they were saying. And then I asked my parents to get a subscription for me to the Reader's Digest, which actually had a medical section. And those were the days of the people down in Texas doing all the heart surgery, the Backey, Cooley, and the sort. And I was fascinated by this because I think I have a mechanical mind, so that like most surgeons, surgeons have obviously understand mechanics, and it made sense to me. I understood what I was reading, so I got interested even more in medicine, and from there it just carried on to high school, and then biology in high school, and then eventually university.
So I mean, you went into medicine. I mean, but how did you end up in ophthalmology?
Ophthalmology, so medicine was a well thought decision. I never had a doubt that I would become a doctor. I never even dreamt that I'd be an ophthalmologist, because ophthalmology was such a small, unimportant part of my curriculum that I really didn't think it made a difference. Then I stumbled upon ophthalmology because I had a friend that was a bit older than I was, and he decided to become an ophthalmologist, and he spoke to me about ophthalmology and how exciting it was, because ophthalmology at the time was actually blossoming with all the lasers and the technology and the possibility of having the medical part and the surgical part. It was such an exciting field that no other discipline had such a growth. And we were lucky enough to witness this growth in the late 80s and 90s, because most of the things we enjoy today were actually developed, as you know, in those days.
That's true. Okay, so I mean, I know that you're a genuine ophthalmologist. You work everything. but I mean,
Paul to Paul, as our friend
yes,
Forlini
Paul
would
to
say.
Paul,
Yes, yes.
our dear friend Forlini.
Yes.
Is vitreoretinal your favorite?
Yes. Well, you see, I enjoy all surgery just like you. Um, uh, but vitreoretinal, again, has a diversity that no other surgery has. And if you associate with vitreoretina the other things that go along with it, spanning from the fact that you have to deal with a complex cataract, to luxated nucleus or IOL, to implanting a valve because you have a glaucoma which does not respond to any other therapy. It becomes really a very, very rich field that never leaves, never bores you, never. It's always challenging. It's always challenging. It's never repetitive. It's always challenging. Even a macular hole, as you know, is never the same. Even an epiretinal membrane is never the same. So it is very challenging. And when you get into more complex surgery, as proliferative diabetics and so forth, it really makes a difference to the patient. And when you're successful, it really makes your day. So it's very gratifying. Yeah.
So you've been working, you worked in Italy, and you're actually working in the UK now. So, I mean, what's the difference between working the ophthalmology practice in Italy and that in the UK?
So, as you know, I worked most of my life in Italy with the NHS and also with a private practice. In Europe, the two countries are very similar, the UK and Italy, because they both have a national health system where it's universal free medical care. And then you have the possibility to have private practice as well. The two systems are, I would say, are carbon copies of each other. So they're very, very, very similar, with obviously national characteristics, but they're very similar. The reason why I chose eventually to go to England was the fact that I had done most of my work with the NHS in Italy for many, many years. Shall we say how many, or will we give away our age? For many years, let's say. And I reached my maximum contributions, really. What more could I do? So I wanted to gift my young children, because I always say I'm a late bloomer. I met my wife late, and I wanted to give them the gift of knowing a language properly with no accent, just like you. And you, as you said, a bit like myself. So the possibility of mastering a language, and therefore, when you have that, you open all doors to the world. And what better way if not to bring them to a country where they could go to school and learn the language properly. And that's what we decided to do, my wife and I. And so we landed here. I was fortunate enough to be asked to work as a consultant with a very large hospital. It is the fourth largest in the country. It's a university hospital. It's University Hospital Sussex, as you know, and continue my passion, which is vitreoretinal surgery. Obviously, I could not leave my private practice in Italy, because after 30 years and 30 years of patients' devotion and my devotion to patients, and also to the staff there, I could not leave that. And so I was, again, fortunate enough to organize my life in a way where I can do both. So I work 3 weeks here, and I fly back a week, where I find that my patients have been seen by the staff at my office. I will do the surgery, and then the patients are taken care of by staff there, by the doctors that are there, and I fly back here where I continue to work. So,
very hectic.
very. The airlines are very happy.
Sure. Okay, so now we shift to gastronomy, and well, don't tell me that you are a fan of fish and chips. No.
I tell you, fish and chips is good. Fish and chips is good. But because the fish is very high quality. But so I take away the batter and I eat the fish.
So what's your favorite food, Gianpaolo?
Oh gosh, my favorite food. I have many favorite food. I would say that generally it's pasta dishes. So shall we say lasagna? Very, very.
Right. Okay. So you're a really dedicated Italian. Okay.
Absolutely.
Right. So now that we have really got to know Gianpaolo Gini inside out, so I think now it's time to go to the scientific part, where Gianpaolo is going to give us a presentation of his choice. Now we take a pause and we'll join you in a minute. We're back again with Gianpaolo Gini and his presentation. Gianpaolo, could you share your screen, please?
So, of the many topics which we could talk about today, I would like to talk about post-interventional endophthalmitis. And the reason for doing that is, even today, after many years from the early vitrectomy study, we still see that patients are not getting, in my opinion, the right treatment for post-interventional endophthalmitis. So I would like to emphasize that although we know that at some stage it is accepted that vitrectomy may come into the equation in the treatment of these patients, many times the timing or the modalities are not correct. That is why I would like to go through the main points that I think are important in dealing with these patients. Now, point number one is understanding what endophthalmitis is. It is an abscess. It's a closed abscess. It has all the criteria of a closed abscess. And we know from our basic medical studies that any abscess needs to be drained, which leads us to point number two. So endophthalmitis should be regarded as a surgical emergency rather than a medical one. Point number three is that endophthalmitis is a dynamic event. This means that it has a tendency to progress in time, which obviously leads to point number four about early treatment. The importance of time in the final outcome of an endophthalmitis case should be emphasized, perhaps by using the terms early rather than moderate and advanced rather than severe. This makes us understand that it is a dynamic process. It's not a picture that you see and it doesn't change. Point number five is the rationale for vitrectomy. So why would we want to treat our patients with vitrectomy? Well, we know that removing the infective agent faster and more efficiently than can ever be achieved with just intravitreal antibiotics is going to do a lot of good to that eye. And also removing the inflammatory component will be beneficial. So on the other hand, foregoing vitrectomy delays and limits visual rehabilitation, and it requires reoperations more frequently. We know from the early vitrectomy study that no eye having undergone vitrectomy required a reoperation, whereas 6% of those that did not have a vitrectomy required a reoperation. Why was this the case? How can we explain this tendency not to operate early on these eyes? Well, it was an unjustified fear of iatrogenic retinal detachment, and this limited the indications for vitrectomy in the early vitrectomy study. And even though the early vitrectomy study showed that actually the patients that had vitrectomy had 2.5 times less incidence of retinal detachment as opposed to the ones that did not. Even more today, this is an unjustified fear because of the technological advances which have made this procedure much safer in the past. So much safe that we now consider phlebotorectomy to be one of the procedures which we can offer our patients. So point number 6 is the concept of dealing with these patients with complete and early vitrectomy. And this should be seen as the golden standard in treating post-interventional endophthalmitis. Now, what is the role of intravitreal antibiotics? Well, we can see a role for them in a limited number of cases, which are actually detected very early and where there are clear contraindications to pursuing vitrectomy. Now, this, however, does require a very close follow-up of the patients so as to be ready to intervene if the situation deteriorates. So one must have a setup where the patient is continuously monitored. Otherwise, you could see the role of intravitreal antibiotics as an intermediate step to limit the pathogen proliferation while we're waiting for vitrectomy to take place. The technique itself, it follows different steps. The first is to obtain a generous vitreous sample. And the way to do that is to use the dry tap technique, where we can use air instead of BSS in the infusion. And this allows us to obtain unlimited, really, amounts of vitreous without risking hypotony, while not diluting the obtained material with a BSS. The technique goes on to achieve the best possible view at all times. Occasionally, you may have to deal with an edematous cornea by removing the epithelium. Very rarely, you may even need to use TKPs. You must proceed from the top towards from the front towards the back of the eye. So you're looking at the cornea, then you're looking at the anterior chamber, which has to be cleared of fibrin and debris. You may or sometimes have problems dilating these pupils. The pupils are generally myotic, so you will have to resort to the use of mechanical pupil dilators so that you can have a better view, and you can access, as you should at all times, or try to access, the ciliary body. You will then start your actual vitrectomy by removing the posterior part, the anterior vitreous, which is the vitreous which touches the lens itself, and you can perform a wide posterior capsulotomy without removing the IOL. So this is another message which I would like to give you. You don't need to remove the IOL at all times. All you need to do is create a large capsulotomy, which allows the antibiotics within the vitreous cavity to go through the capsule, and the antibiotics which are in the anterior part of the eye to go into the bag. The IOL can stay in. You continue your vitrectomy, your real vitrectomy now, in a perpendicular fashion rather than a tangential one. Why is that? Because if you have a detached retina and you're sweeping your vitrectomy probe in a tangential fashion, you may end up cutting into the retina without noticing it. If you go straight down on the nasal side of the optic disc, if you were to find the retina and cut through it, the damage would be, although undesirable, but it would be limited, because you are obviously not you're not dealing with the macular area. So you create a tunnel which aims to reach the back of the eye on the nasal disc. And once you have identified the retina, you use that as a reference plane to move tangentially now towards the periphery of the globe. So if you see the retina, you continue to move outwards towards the periphery and then upwards towards the ciliary body. If you cannot, or if you're in doubt, you must stop. And this is another important message. You must perform a complete early vitrectomy. Well, when I say complete, I always say within your comfort zone, according to the case that you have in hand, and according to the skills which you possess. Do not go and try to do something that you will regret. Finally, I would recommend not to attempt a posterior hyaloid detachment, which can result in iatrogenic tears. If necessary, if you think that you want to remove the pus from the macula, as you should, and open up the macula to bathe it with the antibiotics which are contained in the vitreous cavity, you can use the fenestration technique, which is shown in this video. Now, this video just goes through the steps I have illustrated previously. You can see the capsulotomy is being performed, a very large capsulotomy. We have reached the posterior pole. We have cleaned the periphery rather well. And now we're dealing just with the pus, which is on the macula, which we call the macular hypopyon. You aspirate this pus, but you have a thick hyaloid which actually covers the macula and can prevent the antibiotics from reaching the retinal tissue itself. So rather than attempting a posterior hyaloid detachment, you gently fenestrate or open the hyaloid over the macula so as to prevent traction that is very tight, as you can see here, where I'm showing how the hyaloid is very much attached to the blood vessels, and attempting to remove that, as we generally do, would create a retinal tear, one or more iatrogenic tears. So you have fenestrated or opened up the macula in this way. Now, the use of antibiotics, I generally start by obtaining a sample of vitreous, and then from there, I introduce antibiotics directly in the infusion bottle. I use higher concentrations than generally accepted for intravitreal injections, and I generally use vancomycin in the concentration of 1 milligram per milliliter, so 500 milligrams in 500 milliliters of BSS. At the end of the procedure, why do I do this? I do this because I feel that the antibiotic will diffuse much better. Wherever my vitreous cutter goes, the antibiotic follows. And I'm really getting what I want, the antibiotic to reach all parts of the eye where I have actually reached with my vitrectomy probe. At the end, I will add, as per standard intravitreal injections, 0.1 milliliters of vancomycin and 0.1 milliliters of ceftazidime. Needless to say, you can use steroids. Steroids are definitely, you can use dexamethasone in the infusion. There's no contraindication to that if you wish to do so. Now, when it comes to silicone oil is always a hot topic for discussion. It is obviously mandatory if there is a iatrogenic break. There's no doubt about that. It is also very useful if you have not performed a complete vitrectomy, or if you think that there is enough debris left that the following day you will have difficulty seeing the retina, exploring the retina. Because obviously silicone oil will give you a very good view of the retina post-op. But silicone oil has to be removed, and it has no specific advantage as an antimicrobial agent. Therefore, it is not mandatory, and many procedures can terminate with BSS and antibiotic being present in the vitreous cavity. I thank you, and I hope this was a useful presentation, and that you will be using early, complete vitrectomy in your patients when and if, unfortunately, you find yourself faced with post-interventional endophthalmitis case. Thank you.
Thank you very much, Gianpaolo, for touching on this topic, which is a nightmare to any ophthalmologist, actually.
Yeah. I hope we said, I skipped a few things, such as the use of antibiotics, but we can, if there is discussion, we can talk about that. But
let me go to real life. So you get a patient with endophthalmitis. The logistics of preparing the operating theater in itself will delay your intervention. So the operating theater is occupied. You really have to notify them, and then there's a list going on. But how do you deal with your endophthalmitis case? I mean, with the operating theater. I mean, do you inject them in the outpatient clinic as a time, because the clock is ticking, as you just mentioned.
Exactly.
Until they are operated.
Okay, so obviously you have to, every case is different. You have an endophthalmitis that comes in and you know that it's the end of the day and you'll be able to get the staff operational in a few hours, 1-2 hours, just nothing that needs to be done. You get it at 9 a.m. and they tell you that your operating room is going to be taken up until the evening. Obviously, you can't wait. So what you must do, as you pointed out, in our patients, you simply perform a tap and you introduce blindly antibiotics, so vancomycin and ceftazidime, and then you wait until you can go and perform your vitrectomy.
Right. Are you in favor of using intracameral antibiotics intraoperatively as a prophylaxis for the cases?
That's a very good question. For the single patient, absolutely. I think it works very well. As a medical practice, I'm not sure, because obviously we know that we are, in the long run, we are determining resistance. And that is not something that we as doctors would like to see. But for the single patient, yes, and therefore we cannot deny that it is very useful.
Right. Okay, so one last question about, I mean, I've noticed that post-op and in the endophthalmitis cases, you get those inflammatory membranes and epiretinal membranes, which are sometimes so tough and so adherent to the retina that you really have difficulty removing them with ease. Do you have any tricks in this respect?
No, what I did not mention in my presentation, which I forgot, or I simply skipped over very quickly. The use of steroids systemically and antibiotics systemically can also help, because we know that the blood-brain barrier has been broken down by the inflammation itself and by the vitrectomy. This can help reduce the formation of these very tough membranes. But once you have them, it's just like PVR. I mean, you've got membranes, they're very adherent, and you have to deal with them. Obviously, what you would like to do is to intervene when everything has cooled off, and therefore the retina has had time to heal. Otherwise, you'll be dealing with a necrotic and fragile retina, which can tear very easily. So that's the only suggestion I can give. But what you mentioned, actually, sometimes you get these incredible inflammatory reactions, which can be possibly be mitigated by the use of routine use of dexamethasone in the infusion, because you get these. They remind me of the trabeculum of the bone marrow, because you see inside the vitreous, you see all these strands in the vitreous cavity, all these strands that go from one end to the other of the globe, and those are just inflammatory bands which form within the vitreous. Those are really a sign of intense inflammatory response. Have you found those?
Yes. Yeah, that's true.
So you're led to believe you still have the infection, but actually you don't have the infection. Those are just a very strong inflammatory reaction.
Yes, that's true. I mean, those cases, even after vitrectomy, they have a stormy post-op, but give the patient time. And sometimes you really have to inject other antibiotics, or sometimes you might need to wash again.
Wash, and in those cases, then silicone oil may be required because it occupies space. But when you put the silicone oil in, what happens is that you're confining all those inflammatory reactions to the retina itself. So you're really moving the problem elsewhere. You're not really getting rid of it. So it's a difficult call. But I still believe that if you and I know that you share my view, if you're lucky enough to intervene in a timely fashion, if your pathogen is not particularly aggressive, you have good chances of dealing with this effectively, and your patient has good chances of regaining very useful vision.
Yes. Well, thank you very much.
Thank you.
Thank you, Gianpaolo Gini, for joining us in our tour around the retina world in 30 days. And I hope you are able to save many, many eyes with the early technique. We're really very happy to have you as an old friend of EGVRS, and hope to see you soon.
Thank you. Thank you. And I do hope that we'll be able to meet again soon in a more peaceful world, free of disease, free of war, and with the ideals that have made us doctors. We love mankind, and we try to do our best to help. And when we see the events that we are surrounded with, it's very, very sad. So we hope in better days to come. Thank you, Mahmoud. Thank you so much. And to all the friends from EGVRS. Thank you.
Thank you.